All right. Good morning, everybody. So we'll get started. Thank you for coming for this Saturday workshop. Appreciate everybody's attendance here. My name is Michael Maximowski. I'm a psychiatrist. I work at the John D. Dingle VA in Detroit. I'm part of the Interdisciplinary Education Subcommittee. And today we'll be talking about non-physician professionals within the academy, making controversial connections, and as a forum for discussion and debate. I have no disclosures. So before we get started, I just wanted to recognize the members of the Interdisciplinary Education Subcommittee, which we have many here. I served as the vice chair this year. Lily served as the chair. And we just want to recognize their contributions to this presentation. A lot of work went into kind of creating this workshop, as well as creating the survey that we'll be talking about within this workshop as well. So I just want to recognize their contributions. It's been great working with them. I've been on the subcommittee for 4 years since I was a web fellow, actually. So really appreciate working with all these individuals. So a quick outline of what we'll talk about today. First, I'll start by giving you a bit of an introduction and background. Then we're actually going to jump ahead to the survey results first. Lily will talk about that. Then we'll go back to explaining the roles and contributions of non-physician providers, educational needs that we might have identified. And then we'll talk as well about later on, that's going to be Tina's part. Then we'll talk about membership approaches from other psychiatric organizations. Lisa's going to be discussing that. And then Paul will actually be talking a little bit about multidisciplinary collaboration amidst palliative care, the palliative care organizations. Then we'll do some time at the end for audience contributions, maybe brainstorming opportunities, discussions, questions, and then we'll wrap up. So a little bit about, oh, by the way, before I get started, is there anyone here that's actually not a physician that's joining us today? Oh, wonderful. This is great. What are some of the professions that you practice? You just shout them out. Social work, great. PA, great. Welcome. Thank you for joining. So a little bit about the background of what we'll do today. So, and just kind of why this is important to discuss. You know, as CL psychiatrists, we kind of are seen as leaders of collaborative care teams. We work with a lot of collaborative care individuals, you know, PAs, NPs, social workers, psychologists, and including trainees. And we're kind of seen as those, you know, leaders of those teams, but we also work with a lot of different disciplines. And collaborative care and proactive models really emphasize the importance of using an interdisciplinary team to provide better care, to provide, you know, improved patient outcomes, reduce lengths of stay. So it's important to understand these roles and the responsibilities, as well as potentially gaps in knowledge on both sides of the spectrum, you know, in terms of physicians and non-physicians, in terms of understanding the roles and responsibilities. So interdisciplinary education as well helps to provide, you know, diversity, equity, inclusion for all members that participate. So a couple of questions to kind of think about as we're going through this presentation. You know, how have other traditionally physician-led organizations approached interdisciplinary membership and education? What is the current ACLP approach? And I'll talk about that in terms of interdisciplinary membership. And what could the organization do or not do, right, about, you know, the membership status? And again, the purpose of this presentation is not necessarily to take, you know, this approach, or rather just to kind of give the information, explain, you know, what we know, and to have an interesting discussion towards the end. So let me start by explaining what is under the ACLP an associate or an allied healthcare professional. So this is, you know, directly from the website and from the bylaws. It's an individual with an advanced degree, at least a master's degree in a related field, and that's actively engaged in CL work. So eligible qualifications, among others, include, you know, PhDs, MPAS, PA certified, Masters of Science in Nursing, doctorates, nurse practitioner, advanced practice nurse practitioners, PAs, and then psychiatric mental health nurse practitioners that are board certified. So membership. Categories in the ACLP, I think that there's a total of, I believe, 9, but the two important ones that I want to talk about today are members and associate members. So members are any psychiatrist who's actively engaged in consultation-liaison psychiatry, and that individual is eligible to become a member of the academy. Any individual with an advanced degree, so the previous slide I mentioned, the associates and allied healthcare professionals who's actively engaged as well in CL work, is eligible to become an associate member. And there's different dues associated with both those categories. Only members, life members, fellows, and life fellows of the Academy may vote at meetings and elections of the Academy. And again, this is from the website. So I highlight these associate organizations, not because the ACLP is associated with these organizations, but rather these are other organizations that allied healthcare professionals may be a part of or be members of in terms of getting educational resources or training resources in terms of working in mental health. So for psychologists, there's a couple. There's the American Psychological Association, the American Academy of Clinical Psychology, and then the National Alliance of Professional Psychology Providers. For physician assistants, there's the Association of PAs in Psychiatry. For NPs or APRNs, there's the American Psychiatric Nurses Association, National Association of Psychiatric Mental Health Nurse Practitioners. And then for social work, there's the National Association of Social Workers. And again, this may not be an exhaustive list. This is just kind of my own research in terms of looking at some of these organizations. And I did but email some of these organizations asking about if they had any specific resources for working with consultation liaison teams, inpatient, outpatient. I didn't get response back from all the organizations. I did get some response back from some of the psychological associations. They have a lot of resources on collaborative care in primary care settings, but not specific to inpatient CL work. So these next two slides will show you kind of the membership and the attendance at the meetings and broken down in terms of different categories. So you hopefully can see it pretty well there. Yep. So you can see that overall membership has grown quite a bit over the years. And the biggest category, of course, is members. Followed by trainees, and trainees include medical students, residents, and fellows. And when I mean fellows, I mean fellows in training. And then associate membership is the allied healthcare professionals. You can see that even though that number is a little lower, it has grown to some degree over the last several years. And because sometimes membership isn't always reflective of how many people actually come to the meetings, I also looked at, registration for the annual meetings. Unfortunately, I don't have the data for this one, but you can see since 2016 that the attendance or the registration has grown somewhat. And then I think we had COVID, and that might have dropped it down a little bit during the virtual sessions. But nevertheless, the registration from allied healthcare professionals has grown a little bit as well, if you look back from 2016. So before I turn it over, I just wanted to point out that there are some resources that we already have on the ACLP website for interdisciplinary education. If you look under member resources and then collaborative care resources, we do have a description of roles and training of different professional disciplines. And that's something that, again, team is going to be talking about more. And then we do have two bibliographies that we created a couple years ago that highlight important articles, chapters, resources for interdisciplinary team members in terms of learning about kind of the bread and butter of what we do in terms of CL psychiatry work. And that's all on the website. So without further ado, I'll turn it over to Lily.
Thank you, Michael. I'm Lily Gershengorn. I'm at NYU, and I will be talking about the survey that the Interdisciplinary Education Subcommittee developed. I have nothing to disclose. So how did the survey kind of come about? As an interdisciplinary education subcommittee, we're all quite passionate about developing educational material for our interdisciplinary teams. And as we were trying to kind of brainstorm, what would those educational materials kind of look like, kind of realized, well, what do our interdisciplinary teams look like? So earlier this year, we developed a survey looking at composition of CL services, physician, non-physician, faculty, trainee members, including perceived educational needs of any non-physician providers. The survey was sent to the members of CL Service Directors, SIG, and CL Fellowship Program Directors, SIG. Okay, so a total of 61 respondents completed the survey. Most were at a university teaching hospital, followed by a government-funded institution. Most services reported seeing adult patients, that was about 82%, while about 13% reported seeing patients younger than 18 years old, and 5% saw both groups. The regional distribution, as you see here, was 38% Northeast, 27% Midwest, 15% Southeast, 15% West, and 7% Southwest. So let me take you on a journey across country. The number of hospital beds that were reported ranged from about 45 to 2,800. Only 4 respondents reported covering more than 1,400 beds. The number of new consultations per week ranged from about 3 to 230. New consults per week correlated with the bed number. So as you see based on the graph, approximately 5 consults per 100 beds. For institutions with over 1,400 beds that I mentioned earlier, and 1 outlier were excluded from the analysis. So of the inpatient consultation services, 67% reported using a standard reactive approach, and 33% reported a partially proactive approach. Among institutions using a partially proactive approach, the fraction of proactive consultations ranged from 2 to 50, averaging about 22%. So here it's important to note that we have 1/3 of services that are partially proactive, demonstrating the trend toward more of a proactive CL service. Now let's take an even closer look at the inpatient CL services here. Of the psychiatric inpatient consultation services, 92% reported having a psychiatric resident. So we're looking at the trainee composition. 90% reported medical students and 80% CL fellows. Of note, 44% had nurse practitioner trainees and 31% had physician assistant trainees. However, most of the trainees were present less than about 50% of the time on the service. Of the 60 inpatient CL services who reported FTEs, total inpatient CL attending psychiatrist time ranged from about 0.4 to 14 FTE. So that's total psychiatrist time, and total CL resources ranging from 0.4 to 32 FTE. So this includes physicians and non-physician providers and personnel. Based on the chart, you see 42% of services had either an NP or a PA or both. 35% of services included social work staffing, and 32% included psychologist staffing. Now, there was a significant relationship between total prescribers FTE and the number of hospital beds. Approximately 0.8 prescriber FTE per 100 beds. So another critical consideration for us was how CL services approach the needs of patients with substance use disorders. Most respondents indicated that addiction patients were primarily seen by psychiatrists on the CL service, that's about 62%, while 3.3% here are a separate section of the psychiatric consultation service. 16% of institutions have services staffed by physicians boarded in addiction medicine, and 5% of institutions have services staffed by non-physician personnel. Okay, let's shift into the outpatient world. So here we see 59% of services reported staffing at least 1 outpatient clinic. A total of 164 clinics were reported. Most common clinics included transplant, psycho-oncology, women's mental health, HIV, neurology, and internal medicine primary care. Now, internal medicine primary care clinics had the highest proportion of interdisciplinary staffing, and that was about 81%. So this is a closer look at the interdisciplinary staffing within the internal medicine primary care clinic, which had the highest proportion of interdisciplinary staff. So 13 clinics provided data on FTE of different providers. Interestingly, psychologists here were present in about 30% of the clinics, similar to the inpatient CL teams. Nurse practitioner and RNs, registered nurses, were reported at lower rates than on the inpatient CL teams. And here you see nurse practitioner reported by 7% of services, And 19 outpatient interdisciplinary clinics reported on the presence of trainees. CL fellows were the most common, followed by psychiatry residents. And here again of note, postdoc psychologists were reported at higher frequency than non-CL fellows and non-psychiatric residents. So CL services are often tasked with covering psychiatry consults in the emergency department. And this is a closer look at those services. 19 services, about 31% of respondents, reported providing services in the emergency department. Most commonly placed trainees were CL fellows and psychiatry residents. Here we see NP trainees as well as pre- and postdoc psychologists and social work students. 14 services reported data on FTE of different providers. 29% of services who covered the ED teams included social work FTE, which appears to be the most common non-physician provider type. So let's take a look ahead. We asked the respondents to tell us if they're planning to hire in the next year. And here are the results. About 58% of respondents indicated they expect to hire new staff. Now the graph shows the hiring trends for the 67 expected positions to be filled. These most commonly include psychiatrists, so about 43% of new hires, and NPs about 22%, followed by social work and psychologist. So another way of looking at it, of expected new hires in the next year, 57% are for non-physicians. So we asked about the perceived needs of the interdisciplinary teams in terms of the educational materials. And here we see most common answers were educational materials kind of pertaining to the most common psychiatric conditions seen on the CL service, as well as the psychopharmacology of the medically complex patient. The educational modalities, kind of the best way that we could present and offer the material, was felt to be through a webinar on high-yield topics and recordings of high-yield conference talks. So putting it all together, we're an exciting and growing subspecialty. And as we continue to grow, our interdisciplinary teams expand. So when we consider educational materials and modalities for interdisciplinary team members, we really have to consider how we think about the overall training experience and the educational background of the members on the teams. And this is something that the next speakers will be discussing, the educational backgrounds of the various disciplines, and consider how other subspecialties and organizations approach membership of non-physician prescribers. Thank you.
Good morning, everybody. So my name is Tina Bezai. I'm very glad to be speaking here this morning, especially that it's in person. And I am a CL psychiatrist. I am in San Diego. I am the program director for the CL Fellowship, and my clinical work is mainly at VA San Diego on the CL service, and I'm also associate chief of psychiatry there. I will share with everybody the VA San Diego has recently been renamed the Jennifer Moreno VA. It's the first VA named after a woman, so that's a very exciting bit of news just to share. Part of my job, a couple areas where I work in interdisciplinary teams include on our consult service, we have designed it just as an example as an interprofessional team. And so we have a CL Psychiatry fellow, a behavioral medicine psychology fellow, and a psychiatric pharmacy resident. And that is our trainee team, and we have a group of faculty in that same group. Another area where I work with interdisciplinary teams is on the ethics team, and that's a wide range of different disciplines. And then finally, as Associate Chief of Psychiatry, I develop educational events for the psychiatrists, psychiatric pharmacists, and nurse practitioners at our VA. And so nurse practitioners are now independent practitioners throughout the VA system. And so that's a fairly new development, but exciting. Okay, so I am going to talk about non-physician providers in CL psychiatry settings, roles, responsibilities, and educational needs. I'll preface this by saying when I started to develop this PowerPoint, covering everybody's educational background was such a huge task. I quickly had 30 slides for 10 minutes. And so I have really pared it down. I hope I've gotten things right, but I'm going to more do a brief overview. I have no disclosures. So one resource I utilized was the ACLP Interdisciplinary Education Subcommittee developed a team member guide, which was called Understanding Roles, Training, and Collaboration Strategies. This was approved in March 2019, and I want to give credit to the subcommittee and also Sheila Lahijani and Anna Ratzliff for being the authors of that publication. The link is below. Some of my following slides are based on the information in that document. It's a 3 to 4 page document and reviews different disciplines and collaboration strategies. So I thought I would briefly go over some of the non-physician team members, but then focus on physician assistants and nurse practitioners a bit more in depth. And so just in brief, and I think everybody will have these slides. I'm not going to sit here and read the slides. But our psychology colleagues can have 2 different doctorates, and they can have PsyD or a PhD. And just for folks to know, PsyDs are trained with the focus on clinical practice, PhDs in a scientific practitioner model. PhD takes a bit time more, and there are more subfields, let's say extensive subfields related to research categories as well. Social work, there is a requirement for a bachelor's, and then social work case managers go on to have the requirement of 3 years plus 4,500 hours in a case management agency. And then can be involved in the role and responsibility of case and care management. Master of social work is our colleagues that are licensed clinical social workers, and that's 2 years with then state licensure. These are colleagues we work very closely with. They provide diagnostic assessments, psychotherapies. I work with psychiatric pharmacists very closely. How many people in the audience work with psychiatric pharmacists? So, all right, so quite a few. So especially at the VA, psychiatric pharmacists have close to independent functioning, I will say. They do not diagnose, that they provide continuity of care, outpatient medication management, medication adjustments, important members of inpatient teams, outpatient teams. And so there is, pharmacists have a doctorate, and then they have a 1-year residency that is general competencies, and then they have a 2nd year, which is psychiatric competencies. And so the psychiatric pharmacy resident that rotates with me is a 2nd year pharmacy resident. Registered nurses have, and this is where I really went down a rabbit hole, and I hope I have it kind of in general correct, but it made me realize how much I don't know. So you can have a bachelor's of science in nursing, a master's of science in nursing, which is a different duration. And then depending on what state, there are scope of practice differences between states. Clinical nurse specialists are master level, and provide leadership in education, teaching, therapies. So advanced practice registered nurses there are actually 4 recognized types of advanced practice registered nurses: NPs, certified registered nurse anesthetists, certified nurse midwives, and clinical nurse specialist. And so I'm going to really talk about NPs. Historically, it looked to me like NPs could have a master's of science in nursing or a doctor of nursing practice. In 2025, there's going to be a requirement all will have a DNP. And so that's 3 years for that doctor of nursing practice, so 7 to 9 years total. Oops, sorry, let me go back. Okay. Oh, no. There we go. Nurse practitioners, when they do their curriculum and their clinical practice, select a health population focus area. And I've included these on the slide. And so it could be adult gerontology acute, adult gerontology primary care, family, neonatal, pediatric, psychiatric mental health, and women's health. So at the VA, some of the hospitalists are nurse practitioners, and they, when I spoke to them, have done the adult gerontology acute, generally speaking. Historically, I think hospitalist NPs have included, I think, family or adult primary care, but the nurse practitioner told me the field is moving towards really the acute gerontology population focus. And so when we have nurse practitioners on the CL service or in collaborative care, in general, they've had the health population focus area of psychiatric mental health. So there are state and national licensing requirements. I think I was looking at this morning. I may have gotten this wrong. 1,000 hours of clinical practice. I think it's actually 500. Thank you. And so diagnostic assessment, prescribing medications, providing some therapies, independent practice in some states. This is a map on November 5th that shows the nurse practitioner state practice environment. And so green is full practice, yellow is reduced practice, which means there needs to be a collaborative relationship. Red, restricted, there has to be a supervisory relationship. And so you can see nurse practitioners have independent authority to practice in many states. I will say, just since I'm from California, a law has been passed, and in January they will be independent in California. I already mentioned in the VA system, independent. So important colleagues, they're filling a variety of positions that we're collaborating and working with. And so we need to understand educational background and maximize working together. Physician's assistant. So there's a bachelor's degree with 3 years of health experience prior to then going into a PA program, which is a master's degree program. And that is 25 months to 3 years. It's a medical model, trained as a generalist. And then the PAs can go on and get a psychiatric certificate of added qualifications, which is specifically 150 hours of CME, psychiatric, 2,000 hours of practice, patient care requirements with attestation by a supervising physician. Most state laws require an agreement with a supervising physician. 2 states currently allow without. Some of the restrictions, my understanding, were lifted during COVID. Unclear how that's going to evolve moving forward. This is a chart which is from that document I shared in the beginning, but originally was from actually a North Carolina Psychiatric Association. I don't know if anybody here is from North Carolina, that kind of charted it out a little bit differently. Total patient care hours required, amount of clinical rotations in psychiatry. And, this is psychiatrist, primary care, nurse practitioner. So again, I think this is 500 hours. And then PA and with the added certificate. So you can see there's a diverse range of hours, experiences in colleagues that we're working very closely with. So this is from an article by Dr. Navoa, who is at Denver Health. I actually saw him earlier at the conference. Essentially the crux of the problem that we have in mental health is that there's a significant shortage. I'm sure we're all aware of psychiatric providers. And, 1 in 5 adults in the USA experiences mental illness in a given 1-year period. 41% of those will receive mental health care. And so there was a 2016 HRSA report. This was actually, when you think of it, before COVID, because now after COVID, I can tell you it's whatever that was is amplified. But they recommended increasing recruitment of medical students, increasing psychiatry residency positions, increasing telepsychiatry, which we all know has been dramatically increased, implementation of collaborative care models where the expertise of psychiatrists can be leveraged to a population, and development of residencies and fellowships for NPs and PAs. So I want to spend just a couple minutes talking about the development of nursing fellowships and PA fellowships, and then talk about how our organization could potentially contribute. So this is from an article by Delaney in the Archives of Psychiatric Nursing. And she talks about how there is some different opinions amongst nurse practitioners as to whether further additional training is needed, but that there have been some perceived barriers in a transition to practice, the quality of professional relationships, time to complete work, and perceived competency. There's certain specialties, oncology and orthopedics have argued historically that the training doesn't devote enough time, the population health training doesn't devote enough time to specific competencies in the specialty area. And so they recommended moving towards, in specific specialty areas, competency-based further training. Advanced practice nurses are addressing significant complexity of care in federally qualified health centers, acute care, chronic conditions, multiple comorbidities, extremely complex care. And so, and with that and the projection that hospitalist and acute care roles will increasingly be filled by NPs, is the recommendation that there be further focused training in hospitalist and critical care. And with that, of course, CL Psychiatry is functioning right at the interface of medicine and psychiatry and manages a lot of complexity. So I would include CL Psychiatry in that group. And so of note, recently HRSA awarded grants for NP fellowships to 35 academic practice consortiums. Majority were aimed at family NP graduates. One was at family NP and primary mental health NP and integrated care. And the idea that this will likely lead to the development of standardized fellowship curriculums for these specialty areas. And there is the precedent of Hospital and Palliative Nurses Association in 2015 identified standards for clinical practicum for palliative nursing. These are just a couple. I was just browsing the web, as we all do. But this is UCSD has a nurse practitioner fellowship program. They are also going to start a PA fellowship program. This other example, I have to kind of look here, I believe is Harvard Center for Palliative Care, nurse practitioner fellowships. There are many that are being developed. I'm going to cite this other article Navoa wrote about the development of PA fellowships with the example of Denver Health. So Denver Health, the background on that was the exposure in PA school to behavioral health was variable. It could be 2 to 4 weeks. And then, like I mentioned earlier, there's that psychiatric added qualification certificate. And so they started a fellowship, a 1 year that exposes the PAs to a variety of clinical settings, preparing them to sit for that exam. There are 4 3-month-long blocks: outpatient, emergency room, CL, and correctional. The CL rotation focused on evaluation, diagnosis, role of the consultant, and managing behavioral health issues with supervision. Core faculty included PAs, psychiatry, daily supervision of clinical cases. And the program is hosted by the academic psychiatry department. So the trainees go to seminars, grand rounds, case conferences, journal club. Spoke about in the article about potential benefits, which is that medical students are then going through their training, working with PA trainees, and this will facilitate and improve future collaborative relationship. And that also the psychiatry residents and fellows will also be able to do that, as well as develop as teachers. Future directions at Denver Health included adding inpatient and developing a PA fellow-specific didactic. So again, looking at kind of particular specific needs, competencies, and focusing the curriculum on that. Couple examples on the web I found here: a psychiatry certificate at Rocky Mountain University for PAs, and then at Sloan Kettering, a combined NPPA fellowship in hospital. So some are combining, some are separate. There's a lot of movement going on. And so just a final comment. This is a editorial that was in that I wanted to bring to your attention: supporting the education of nurse practitioners and physician assistants in meeting shortages in mental health care. We're all here to provide patient care, improve patient outcomes. There is a significant shortage of psychiatrists, despite 20% increase in residency positions. This editorial talks about how psychiatrists are stakeholders in the systems of training. We are colleagues, stakeholders. And so then comes the question of what are the roles and responsibilities of CL psychiatrists as we look ahead at the future, and how will educational programs interface with CL fellowships? How does our organization play a role in this? And so with that, I am going to end. I have some references here for folks to look at, and I will pass the presentation on to Lisa.
All right. Well, thank you, Tina. And again, pleasure to be here. I'm Lisa Giles. I'm a pediatrician and child psychiatrist. Do CL work at the Children's Hospital, Primary Children's Hospital in Salt Lake City, Utah, and do some integrated outpatient work as well. My job today is really to talk about what are other groups doing. I have no disclosures to report, but really it's when we start talking about membership in these professional organizations, what does it look like? And so I'm going to provide just a really kind of brief overview to a handful of physician organizations I kind of arbitrarily picked, and then walk through kind of the specific story associated with some of our psychiatric subspecialty groups on either end of the lifespan and kind of the different approaches that they took. So this slide is simply a snapshot, right, of a number of different physician organizations. American College of Physicians is kind of the internal medicine large group, family physicians group, the American Academy of Pediatrics, hospitalist medicine, GI in particular, I picked out for reasons I'll explain in a minute, and then of course our American Psychiatric Association. And as you can see from this slide, almost all physician organizations allow some sort of membership for physicians that are not like board certified in that specialty, right? So for example, the American College of Physicians has membership for internal medicine docs, but you can also join if you're a physician that didn't board certify in internal medicine, but you're involved in that area. And that's what most organizations have done for other physicians. But then we start looking at kind of those non-physician roles, right? And what does that look like? And certainly we do have a number of physicians that just have absolutely no membership for non-physicians. The American Academy of Family Physicians is one of those. They have no non-physician group. The American Psychiatric Association has no non-physician group. But again, it's not uncommon for a lot of these organizations to have some non-physician group, but then generally they don't, like it's some sort of affiliate membership or associate membership that doesn't allow like voting privileges or leadership roles in that organization. And so, like, again, the American College of Physicians, they do have an affiliate membership for PAs, NPs, RNs, pharmacists, and psychologists, but they do not have a leadership role or kind of voting membership in the organization. I included the American College of Gastroenterology because they were a little unique in that they actually allowed some. So you could be a member, kind of that full membership with leadership and voting. Their qualifications were if you have a graduate degree defined as a doctoral level degree in a specialization related to basic or clinical science. So basically psychologists and PharmDs could have full membership, but then they have a separate affiliate membership for NPs and PAs. And so again, those could not have leadership and voting roles, but the others could. So you see kind of this wide variety, I think, as all physician organizations kind of, try to answer some of these questions and figure out, what does this mean in terms of membership beyond physicians. So I want to, again, walk you through kind of pathways that some of our other subspecialty organizations, specifically psychiatry, have looked at. And I'm going to talk about ACAP, kind of my home, the American Academy of Child and Adolescent Psychiatry. And then on the other end of the spectrum, the American Academy of Geriatric Psychiatry, because they both went through kind of similar processes and yet came to very different decisions. And so I think it's helpful to look at those. So ACAP, the American Academy of Child and Adolescent Psychiatry, started this journey back in probably about 2014 is when they started really kind of raising that question of, what should we be doing with kind of our non-physician colleagues? And what does that look like? And so there was a specific task force assigned. I think it was interesting to note historically that this was when like the president of ACAP was someone that's really into integrated care and that collaborative care world, and so worked in that world, and so assigned kind of a task force to really start looking at this. There were a number of town halls held, especially, so we're talking like 2016 town halls to talk, and the focus was really in this pediatric space was really on psychologists, because that's who was really prominent in terms of kind of the non-physician colleagues in the child psychiatry world. And so really looking at what would that look like to bring on our psychology colleagues to membership. And so town halls were held and then opinions were solicited. So a bunch of like surveys were sent out to membership. And then ultimately it was 2018 when the council made a decision. And so this is just kind of some of the common themes that arose in those discussions and opinions in terms of those in support of non-physician members and those that were in support of physician-only membership. So again, advocating for non-physician members, it was that sense of, hey, this will really help us expand our advocacy efforts as we're advocating for children's mental health across systems, that increased interdisciplinary collaboration and really working closely, and hey, this will grow the journal readership, by expanding this. On the other side, there were lots of comments about this is diluting that psychiatric perspective specifically, right? Like us as child psychiatrists, what does this mean? There was also concern that this would appear to support psychologists prescribing, which is a hot topic that comes up periodically. And that ultimately, hey, is this going to take resources away from kind of services and programs to advocate and support child psychiatrists specifically? Ultimately, again, in 2018, the council made the decision not to expand membership. And so ACAP currently, that the membership is still limited to physicians. There's a general membership for child and adolescent psychiatrists, and there's an affiliate membership for physicians who are not child psychiatrists, but have made significant contribution to the field. And interestingly, really, since that council decision was made, that membership question has not come up again, at least, kind of really risen significantly. On the other end of the lifespan, geriatric psychiatry. So again, kind of a similar process, although a little bit later in time. So again, this is more now 2017, 2018, this idea of non-physician membership starts really coming into place. Again, town halls are held, soliciting the opinions of the membership. And then in 2019, a decision is made. And the decision is made to include non-physician membership. And then since then, this continual advocacy to actually increase that and expand leadership roles. So again, kind of looking at this, what were these discussions going on kind of in support of non-physician members or physician-only membership. A lot of this non-physician support was around, look, this is where psychiatric care is headed. This is who is providing psychiatric care today, is including physicians and non-physicians. There was, a lot of this idea that, hey, our academy is for geriatric psychiatry, not necessarily geriatric psychiatrists. And this, hey, this would help us expand. This is a pretty subspecialty area in geriatric psychiatry. What would it look like to be expanding those memberships and really diversifying and recognizing where we are? There was still, similar themes of, hey, this loses our identity as a physician organization, and really concern that, is this going to mean our membership among psychiatrists is going to decline? But again, as I said, that decision was made to do it. And interesting, like in their town hall and stuff, most everyone in the organization was supportive of this move. There really was a fairly high consensus, is what I've been told. So the membership for geriatric psychiatry now includes kind of the psychiatrist member and non-psychiatrist member. They have a board committee position that's held by a non-physician that historically has been an RN or APRN, but certainly is not limited to that. Again, in this effort to try and leadership has had a very specific strategic plan to increase that non-physician role in the academy. And so they now have a new position on the board called the Future Leaders Fellow, which is 5 members, and that's open to both psychiatrists and non-psychiatrists who will attend all the board meetings and kind of participate in that in terms of being a future leader. They're currently in the process of starting a 3-day course in geriatric psychiatry, specifically for non-psychiatrists, that will be available at their annual meeting. And at this point in time, they continue to remain very optimistic about where things are going. Notice they have not lost any psychiatric membership from diversifying, and they've continued to kind of enrich their membership. So that is the journey that I was going to walk you through with both of those programs. And then I will turn it over to Paul.
Hey, thank you. Good morning. So I'm Paul Dazan. I'm the director of a psychiatric consultation service at Yale New Haven Hospital. Here's my disclosure slide. I didn't list on here an important disclosure. I'm an organized medicine junkie. And I admit it, I've been addicted to serving in professional organizations for the last over a quarter century. And I do think it's absolutely essential for physicians to be active in advocacy. And while I've got your attention, I hope you're active in your district branch and contributing there as well as the ACLP at a minimum. So I want to recognize the magnitude of accomplishment with the interdisciplinary subcommittees survey. I think it's really eye-opening. Let me emphasize a few of these points. We've been going around saying that NPs and PAs and other disciplinary professionals are going to be important. And the survey actually says, well, the future is now, and they are very, very important. So that survey, we got responses from 61 psychiatric consultation services, data that included FTE in detail from 59. So we can tell you 42% are using either a nurse practitioner or a physician assistant on the consult service. Now, these are mostly academic hospitals, as you saw in this survey. My suspicion is in the nation at large, there's an even larger fraction. The social workers and psychologists were the next most common use of other disciplinary professionals. You saw that in the services that provided data from their outpatient clinic and from their ED, social workers and psychologists were more prevalent than the nurse practitioners. But certainly consult psychiatry is already interdisciplinary. You also saw the future capitalized, the expected hires. 57% of the positions were the people expected to hire from for consult services were not psychiatrists. Here's an overall summary of the results of the survey. This is staffing in the United States on consult services from the 59 people that provided detailed FTE data. I'll walk you through this. This is organized by the fraction of MD physician involvement. At the bottom, there are some services that are entirely physician run. But as you'll see, the majority of services already are using other disciplinary professionals. In maroon, that's nurse practitioner and PA. It's more nurse practitioner than PA, in fact. The two shades of green are psychologists and social workers, and licensed professional counselors, I think, is included in that as well. And you can see just how important these disciplines have become in our field. Then there's some use of nurses or other professionals, pharmacy professionals, for example, to emphasize where we are right now in consultation psychiatry. The blue is physicians, and the other colors is everybody else. Obviously, we're already a multidisciplinary field. Let me highlight some other trends. Proactivity, everyone will recognize as a approach to consultation psychiatry dear to my heart. A number of organizations are instituting proactive approaches. It increases all of the time. Here's the same kind of diagram showing the prevalence of a proactive approach and the fraction of your total consults done proactively. Our hospital probably being the top line there. Other trends in the survey, addiction medicine is a one-year certification that you can get with any MD background. This is growing extremely rapidly. This little graph here is the growth in fellows in training in our field. This line here is the growth in training in addiction medicine fellows. We add about 2.1, I think it is, fellows per year. They're adding about 44 or 45 fellows per year. So you can expect this to be a major trend in hospitals. I think a number of hospitals are adding services devoted to addiction, and it's addiction medicine doctors who are doing the most of this. Another trend identified in our survey, and certainly in our experience, is in the context of the growth of opiate addiction. A lot of hospitals are introducing specialist services or components of services to deal with opiate addiction. Okay, other trends, well, not so well represented at this meeting, and leaving our survey, which didn't address this, is the rise of providing CL by virtual means. So there are 4 companies that provide most of these such services to all of these hospitals that tend to be in rural or more dispersed locations, harder to get CL practitioners. Out here in our lobby, you saw 2 of these companies set up recruiting tables. This is a major trend in our field. Now, one of those companies has a medical director of CL and has focused on CL. They have 35 providers. 12 of them are CL trained or CL board eligible or board certified. The other is more late to the CL field. They mostly have staffed EDs. They have 60 providers. 3 are board certified in CL. So in terms of identifying trends that we as an academy need to react to, we need to include these providers. We need to get our people into these positions and include these providers in the academy. Needless to say, the folks out here, like everybody else, is complaining about how difficult it is to get psychiatrists, and especially to get CL psychiatrists. Those companies, of course, do appear to be hiring a lot of non-psychiatric professionals, NPs especially. So the last thing I wanted to talk about is one more organization. Lisa told you about how a few organizations had responded. Now, what are we to do in the academy? Well, we can say we're a physician organization, and that's that. We can say we want to broaden our membership and include everybody. I'm not in favor of that myself, but can you expand in an interdisciplinary way and still remain identified as a physician organization? We're hoping to get a seat in the House of Delegates. We want to stay a physician organization. So let me talk a little bit about this organization. This is the American Academy of Hospice and Palliative Medicine. They started in the late 1980s as the Academy of Hospice Physicians, I think, and changed their name to be a little broader in the mid-90s. In 2003, they had about 1,400 members, so the same scale as our organization. Now, they pursued board certification, just like we did, and their field became board certifiable in 2006. They got into a match in 2014, same year we did. They were actually a little ahead of the game. They're already enrolled in ERAS, which I think we need to be enrolled in. But in any event, I think this is a good organization for us to look at as a comparison. Now, they made a decision 20 years ago, and I think a progressive decision, according to what I understand, talking to people within the organization, that came by stages to reach out and include other disciplinary professionals. Well, the result is they now have 5,500 members. 86% the executive director told me in recent weeks, 86% are physicians. So it is still a chiefly physician organization. They went through several iterations of expanding the standing of what they decided to call interdisciplinary members. At the moment, interdisciplinary members can serve on committees. There are 2 seats on the board reserved for interdisciplinary members. They cannot be executive leaders. They have a very large meeting. I think the most recent meeting pre-COVID was about 3,500 attendees, which were still mostly physicians, by the way. Now, what are the consequences of this growth? They were able to expand, I think, in 2 ways. There's a group I've watched online or chatting with people. My sense is that the expansion came both from board certification, but also from the interdisciplinary outreach. But they've still managed to retain their identity as a physician-led organization. But what are the consequences of this? Well, their annual budget is $9 million, about 6 times bigger than ours. That has allowed them to do terrific things. They've received a number of grants. A few years ago, my memory, I lost my note, but I think a few years ago, they got a grant that's $3 million. Right now, their website is showing 1.2 million. So they've been able to have the staff to apply for funding. They have an exceptional set of educational options. They have weekly updates, summaries of journal articles. They have courses. They have different kinds of learning modules. And we have great content, but I think you need the size and scale to be able to package it and get it out there. Their management company, I believe it's Association Management, the executive director told me their total allotment in the management office, counting together all part-time contributions, it's 30 FTE, 30 FTE, 30 full-time employees. That's what you get if you're a larger organization with that kind of scale. This is I know you can't read this. That's deliberate. I couldn't fit all of their staff on one slide. I just wanted to show you, I think, some of their educational options, some of their research options. I'll stop there. I think I made my point. As an academy, we have a choice. And how are we going to reach out to professionals from other disciplines? We employ nurse practitioners, physician assistants, and social workers on our inpatient service. We don't have any psychologists at the moment. They've worked out terrifically well for us. Now, I think out in the community, some of these professions, I have concerns about the level of training before independent practice, but as part of a team where we can train and supervise and collaborate, this is the future. And the academy needs to respond in some organized way towards stepping up to the plate and including these professionals and educating them and being sure they're ready for effective practice. So I'll end there. And I believe, Michael, you're going to organize some questions.
Thanks everyone again for being here. And I just wanted to say thank you as well to the Academy for allowing this to happen, for allowing us to have this this workshop. So really appreciate that as well. So I think what we're going to do is we're going to maybe have everyone from the workshop maybe come up and we can sit up here and we can have a bit of a kind of an open forum discussion, but we can use the microphone as well. So people can sit down here from our workshop. We can just pull up some chairs. we wanted to have time at the end here to have questions, to have discussion, and to hear from you, in terms of your thoughts about this, about what we discussed today. But what I'll do is I'll start by saying, are there any specific questions that people have from the presentation? Let's see. I didn't actually get that set up, I think, through our presentation. I should actually look because I know we have some virtual attendees as well. But while I'm trying to gauge that, does anyone from here have any questions? And if so, if they could step up to the mic. Okay.
Volunteer might hand out the mic.
It's on. It's on. Yeah.
So thank you for all this very informative presentation on a super important topic for us. I was wondering if there's if you know what is the training the mid-level professional receive in CL related topics or CL rotations, and if the academy had any input in that training.
You might need to come up here. I'm sorry. Or we can use the mic. Yeah.
Is there a second microphone back there?
Maybe we should move over more to the middle. I do not think the ACLP has had input as of yet. And I think the training is very diverse in terms of different programs, I think there's a wide range. And so that's kind of the issue is to try to provide more focused educational opportunities for specific competencies that working in a CL setting would be required.
Good morning. I'm going to introduce myself like I do to my patients when I go in to see them. I'm Dr. Lewis. I'm a doctor of advanced practice and a board certified in psychiatry, to make the clarity that I'm not a physician and to make sure that my patients are comfortable with that. So I think that's a very important part of this discussion, is that we identify with our roles and that we're very clear and very transparent with our patients and our colleagues. And that's I want to applaud the Academy, and this is my first time being here, for having this discussion. So there should be no disappointment in whatever the discussion is. We need to have this. And it makes me think of, on our side, nurse practitioner organizations that I'm involved with, and how we partner with our physician colleagues and doing the things that we need to be doing. So this is so important to have that. I wanted to bring a little clarity to some of the points. And I appreciate our VA speaker. I'm going to butcher your names because I'm English and Southern, so I may not say it correctly, but
Bezai, Tina Bezai.
Tina Bezai.
I'll save you. I'll throw you.
Okay, thank you. So I really appreciate your presentation and your clarity on that. Nurse, and I've been the director of a doctoral program, so I can speak from the academic piece as well as a practicing clinician of over 30 years, both in medicine and recently in psychiatry. For that reason, I'm actually a novice in psychiatry. I started a program in 2017, postdoctoral 10 to 15 years out, and have now been practicing in Psych CL since 2020. By default, I will just tell you how it happened. It was clearly by default that I ended up in Psych CL. But nurse practitioners are required by ANCC or ANP to have at least 500 hours before they can sit for their exam. Okay. The average nurse practitioner has 10 years of experience before they go into advanced practice. So that's a lot of hours, a lot of bedside care. Now, there is a new nurse trend of BSN to DNP. So we do have a lot of nurses coming out of BSN programs that are then matriculating very quickly into doctoral programs. It raises a lot of red flags with me. I've taught both at the postmaster's level and the BSN to DNP level, and clearly the postmasters is where I prefer to put my energy and time with these folks. I precept for most all the schools in Virginia, UVA, VCU, James Madison, ODU, all of them. I will only take nurse practitioners right now that are going back for that second certification. Because, and that's a new hybrid that I want to introduce to you, is that we now have dually certified nurse practitioners that are both family or adult or gero and now going into psych. And that brings up a whole nother sort of can of worms of oh, well, these people are pretty valuable, because I could not do my job if I hadn't been a very experienced nurse practitioner on the adult geriatric side. And I don't encourage any new psych NPs who do not have the experience to go into psych CL. And I'm very careful who I pick that I precept. I'm very peculiar. I interview them. I look at their CVs. I don't care what pressure I get from my educational dean. I'm like, I'm not taking them. They're not, I don't have the energy for them. So there is a lot of conversation about what that person brings to this role. Let's see what else I was going to say here. I was going to mention that there's also now a doctor of physician assistant that wasn't mentioned on your thing. This is a fairly new. We have one in our town. Lynchburg College, which is now University of Lynchburg, has a program, and we're working with their fellowship program. They have actually developed a fellowship program that we're going to adapt to our nurse practitioner fellowship. So I'm working on that educational committee to do that with them. Consult liaison psychiatry is not a requirement for any psych NP programs as part of rotation. I will tell you that. Medicine has organized much better than nursing. We're very muddy. We're very messy. We're a very messy profession. We have been for a long time. That you have very distinct rotations. And then from that, you learn. Well, in basic programs, that is the case. In nursing, you go through just about all the rotations. But once you get into advanced practice, you're very focused. I fell into psych consult out of desperation. I was looking for a preceptor, and I thought I was calling one department, and I happened to get Dr. Melissa Bowie. And if you all know her, she was my mentor, and I grieve every day that I'm not working with her now, but I fell into it. And I think one of the reasons that she was attracted to having me as her mentee is because I did have that experience. And it wasn't long after that she said, we need you. This is the experience that you bring to this. And so it's not just the education. It's not just the certification. It's not just the accreditation. It's the experience that that person brings to that role. And I think nursing needs to recognize that. And medicine needs to recognize that. And then this academy has an incredible opportunity to bring that experience to those people. So I applaud you for that. That's what I have to say.
Just before we go on to the next question, I think that brings up a very good point for me about our interdisciplinary subcommittee, and that, there's definitely a need to have not just physicians on that subcommittee, but associate members from, the other disciplines in terms of better understanding educational needs, how we go forward in terms of collaborating more effectively, creating resources. So I'll just make that point.
Hi, my name is Stephanie Taylor. I'm a nurse practitioner from JPS Health Network in Fort Worth. I'm relatively early into my career as a nurse practitioner. I'm 30 years old. I have been a nurse practitioner for 3 years, but I've been doing direct bedside psychiatric care since I was 21, so about 9 years. I have a set of comments, but also some questions for the Academy. This is my first time attending. I do have associate membership. There's been an undercurrent at this conference. I don't think anybody has particularly been not accepting of us, but I kind of at times feel like I'm undercover in a place I'm not supposed to be at. There's medical student mixers, resident mixers. There's special interest groups for different subspecialties and different education levels. I was first wondering if there's any interest in starting like a advanced practice or non-physician specialty special interest group. mixers that could make us feel more welcome, less undercover, so to speak. And then my second comment would be, how would the Academy like to address some of those education inequities? Is there a certain process for certification as a CL, psychiatric nurse practitioner, or PA? You know, I had a really unique experience of being a student at JPS and rotating through PsychR, rotating through CL. We also have one of only 2 joint nurse practitioner PA fellowships in the entire country that's accredited. So what is the educational standard that the Academy would like? And for those people that are interested in it, how do we get engaged in that process? Where's a seat at the table for us to kind of determine what a CL nurse practitioner PA looks like?
So thank you so much for those really wonderful key questions. I think you put your finger on exactly what we want to think about today. And when we reach out, it's not just an intellectual business of, oh, we're going to add this educational thing. We want people to, if we're going to attract people to the meeting, we have to make them feel welcome. And so really appreciate your input. That's exactly the kind of thing we have to think about. Maybe I can ask Marilyn, as our president, to make a few remarks if you'd like, before we end on this, and your plans and what your exciting news you want to talk about. The other thing is, yes, we agree. We need to figure out what is the educational need that we need to fill. What kind of certificate should there be?
Yes, totally agreed. We need your names, Rosie and yourself, for the interdisciplinary committee. So I'd say maybe that's the place to start at the moment while we sort of, this is not going to be a fast process necessarily. We are definitely going to have a meeting or a symposia course for nurse practitioners, PAs, social workers to think about with us what should be the and start at the next meeting with the pre-conference courses. So we're already committed to doing that. And this is a great conversation, great data. So we really appreciate what the interdisciplinary committee is doing, but we need other disciplines represented in the committee as well. So, and you've given us a lot to think about how to make people feel more welcome. It is a tricky thing to navigate because, as Paul said, we haven't made a commitment to decide if we're going to be more than a physician organization. So can we do both? Can we be a physician organization and still make you feel welcome and part of the team and develop curricula with you? I certainly hope so.
I'm Dustin Amossam at JPS with Stephanie. I'm the training director for the categorical psychiatry program and the vice chair of education. And I wanted to answer Paul's question from earlier. Because of our fellowship, residency, whatever postgraduate training you want to give it, it's 1 year long and we have some criteria. If you've been out practicing for 10 years, you really don't need the fellowship. But if you're straight out of school and need some education, it's 1 year. They go to didactics with our residents. So our PGY 1 through 4, so they get 8 hours of protected time. They get assigned rigorous mentorship that they meet with at least once a month. And so that's, and they rotate through all of our service lines, PsychR, CL, inpatient, outpatient. And so that's kind of our model. And we actually we just got accepted for publication in one of the nurse practitioner journals. So that should be coming out somewhat soon. But my comment to this body is, Paul, I think you're right. The 42% is woefully underestimated. We're a community setting, a hybrid community academic setting. I can tell you for certain, those numbers are only going to increase. Our, PAs and NP colleagues, we're living it, and other organizations are capitalizing on that interest in multiple ways, not just financially, but programmatic ways, systematic ways for their institutions. And I think it is imperative. I think it's very important for this organization to really take into consideration those advantages. And sure, there's going to be disadvantages as well, but just I think we should, really take a very close look at how we navigate that in the not too distant future.
Hi, I'm Stacia Mills. I practice in Northern California, and I'm actually on the camp where I'm not excited to have nurse practitioners as far as being independent. And in California, we just had the law where now they're going to be independent practitioners just because the care is different. And the actual training that they receive is vastly different from what you get in medicine. And so my question is more along the lines of advocacy, because whenever I am, trying to make the argument for the differences in education, and so it's just going to be a different experience for the patients, I am always met with the people up above saying, well, this is our bottom line. And so it's not really it's an apples and oranges conversation. And so I'm curious how anybody else has approached this, if they've been in a similar situation.
So, I also want to reinforce a brief comment I made. I think in the CL setting or the ED or one of our clinics, that's really a truly collaborative process. And 500 hours of training doesn't sound like very much to me. To be on your own with 500 hours of training, that doesn't sound like very much to me. But there's a difference with we hope, in collaborative settings. Anyone else want to comment?
I just want to say, I think that's kind of an excellent point, and I'm glad that we're hearing different points of view. Very much appreciate that. This is a conversation that, the subcommittee has been kind of having for a long time. And as an academy, it's a big step for us to kind of open it up and have this kind of open discussion. I'm aware there are kind of studies and publications on, kind of quality of care and cost of care, comparing physician and non-physician. So, that is something that I know kind of often comes up. Just kind of one approach.
The way that I would kind of look at it is that, legally, these are the ways that things have been going in terms of, practice independent versus collaborative versus, supervised. And I think when I've been on the subcommittee, I've looked at, well, given that things are what they are, how do we make sure that we're all on the same page in terms of our understanding of treating our patients, in terms of the education, in terms of the collaboration. And so whatever resources, understanding that we can create or that we can do better about in terms of working together and making sure that we're effectively treating our patients as a team, that's the way that I kind of view things.
So I think it goes back to what maybe Rosie was saying. I think that's a more nuanced comment, because what we're talking about is the beginning of educating people who work with us so that they have the same knowledge base so we can all work effectively as a team. We're not saying that necessarily they're going to replace us. And someone like Rosie, who pointed out, she doesn't take anyone that hasn't had 10 years of experience. It's a little bit like, general practitioners and subspecialists. So CL is a highly subspecialized area in which taking care of complex medically ill patients requires a lot of training. I honestly was trained by a nurse practitioner who had been running the CL service in the children's hospital I worked in for 20 years. And she was a very experienced nurse practitioner. I would trust her, but it really depends on the level of education and experience. So we're saying we want to raise the standard of the experience and training to a minimum start and then work from there. So I think it's got many levels. It's not just opening the door and saying, we're going to be a one big happy organization, but we're starting to just talk with each other and try to help educate so that everyone is getting some basic level of service. We're never going to have enough CL psychiatrists. We're never going to be out of business because technology is always going to expand chronic illness, and patients are living longer with any rare disease. In children, survivorship in cancer is going to be huge. There's millions of survivors now. We can't meet the need alone.
So I'm Nadine Schwartz. I'm a medical director of a CL service in a very large children's hospital, nationwide children's hospital, 600 beds. We're one of the 2 largest pediatric hospitals in the United States. So I have a very large pediatric CL service. I have 4 attendings, but they're not full-time. I have 6 APNs. They're also not full-time, but there are 2 APNs who do 2 full-time shifts 5 days a week, and 1 who does a full-time shift every weekend day. So 365 days a year, we have APNs on service working side by side with our physicians. I would say we have a really great model at NCH. And so I'm going to speak from my own personal anecdotal experience to say, as the leader of the team, it's my responsibility to make sure that everybody who works on my team is educated, is knowledgeable, is collegial, knows their own limitations, including my own self. So I'm triple board trained, which means that I'm not the world's best adult psychiatrist. And so we do have adult patients even at our pediatric hospital. Sometimes they stay until they're 60, depending on their medical condition. And when that happens, I'm the first person to say, gee, I need help with this very old individual because they have, I don't know, some adult problem that needs adult psychiatry help. And that's not my area, like flufenazine, not something I prescribe on a regular basis. Someone help me, please. And so we all need to recognize where our limitations are and where we need help. And so it is my responsibility as a leader of that team on the ground. And so the nurse practitioners who work on my team, and it is my team, right? And so I'm not saying that to be egocentric, but what I'm saying is the buck stops with me. They may be independently licensed and they may be able to go see a patient and sign that note, but that doesn't mean that ultimately speaking, I'm not ultimately responsible for the quality control of what goes on. And so, but it is also my job to make sure that we have a collegial relationship amongst all of us. And so things go a lot better when instead of looking at people and saying, well, what could possibly go wrong here, or that, yes, you've had less training than me, so let's see this as an adversarial thing. It's, well, yes, the fellows also have had less training than me, so my job is to teach them. And the people who are more junior than me have less experience than me. It's also my job to be a resource for them. But I've also had less training in adult psychiatry than some of my colleagues, so I need them to be a resource for me also. And that's, I think, the best approach in general to take, whether you're talking about an NP or a fellow or simply a colleague who might know more than you about a particular situation, no matter how experienced you are. So hopefully that is a helpful perspective.
So my name's Debbie Snyder. I'm a social worker, practice at NIMH. I've been in the field for 30 years. Started in psycho-oncology, master's actually in social work after 5 years. There's additional requirements, but I have to applaud this group because I've been coming to this meeting since 2000. And I had the benefit of having a wonderful mentor and friend. That was Donnie Rosenstein. We grew up at NIH together. And then Marilyn joined our group. He recruited me in 2000 when I was done with the social work department. I was a breast and ovarian cancer social worker, by the way, embedded in teams in a proactive model in distress screening back in 1990. So I'm glad that psychiatry is talking about proactivity now. It's really important. And the integrated care model is, you all are the leads in the spoke of that wheel. And so there's a huge gap. We have to come up with innovative ways to do this. The good news is we're already doing that. So for the folks that are new, I can tell you that the way that the Guild felt in 2000 when I came with an NP was in terms of feeling not like I belonged, but that was partially also internal, which is I had to grow up in this career as well and feel like I had a team to belong to. And once I did, happen to land with an awesome few teams with people that are leaders in the field. And so I've seen change, and I think it's great that we're adding to that. I think it's also important to identify competencies and skill sets and to be able to recognize that we bring different skill sets to the table, but there needs to be active development of curriculum to think about all these positions. And just because you identify as a psychologist or a social worker, you really need to focus on the goals in a particular group, in a particular area, what you need. Do you need a case manager in an ED setting? Do you need a psychotherapist, which was Donnie and my model at the NIH? We're a very different kind of setting, so you need to be setting specific. So while there needs to be minimal standards that have to be defined, there also should be room for sort of where you can grow in areas. I'm really excited and happy to sort of join and be a part of it. I think also mentorship is very important, and having a place where we can do that here would be awesome. Thank
you very much. We're getting close to running out, so we'll have time for one more question.
Yeah, we'll do it together.
Okay.
We'll do it together. All right. So I'm Jeff Stott. I'm the chair of psychiatry at Mayo Clinic. Leo.
Leo Pizzarello, chair at the Cleveland Clinic.
So what I wanted to say, one way to kind of organize the thinking is that there's guild activities and there's field activities. And we've got to keep those in mind. I mean, we're going to go next to a debate about whether or not the fellowship should be streamlined and fast tracked or not. That's a guild activity. That's got to be CL psychiatrists. Similarly with should there be CL training within nurse practitioners? That's a nurse practitioner guild activity. The field activity is bringing everybody in to promote the field of CL psychiatry. We do have to keep those two things separate because we need each of them. Within each of our disciplines, the guild activities, because we've got to interface with our states, the nation, other kinds of things like that. And we have to keep the core of the disciplines true to their disciplines. But then we also have to promote the field and all of us in it.
Just to echo what Jeff said, and first of all, thank you so much for this round of applause to you guys for putting this together. You're being super proactive. One word, retention. We are all suffering with retaining, recruiting, and retention. If we invest in our allied health, we will be able to retain them. A lot of times that offsets some of the monetary considerations that are out there, and we're that partnership that I think we were talking about. So thank you very much.
Thank you very much for coming.